Thanks to the We Care team for inviting me. Before I start, actually, everybody asked me, fortunately or unfortunately, being Secretary of Endocrine Society of India, why men don't do such conferences. So we say that unfortunately we don't do, because if we have to put a tagline, we have to put "we don't care." So we don't intend to do it. So we are thankfully taken care by the learned people here, and thanks for the invite. I go to approach to precocity in girls, and no conflict of interest, and some of the images which I am showing are from the book written by Professor Bansali. I come from a state where actually the menarche is celebrated as a half-sari function. It is a cause of joy, celebration, you call people, everything. But if it happens when you don't want it to happen is the problem. That is what we are going to discuss. If it happens at an appropriate age, absolutely, it's good. But not, then it's a problem. So I shall cover the topic in some of these headings. 3 important facts, 3 types, 3 reports of ours, 3 diagnostic aids, 3 recent advances, and 3 into 5, 15 minutes. I shall finish off early only. So this is a case report, 7-year-old girl brought by parents with history of thelarche. Notice some pubic hair development about 6 months, 1 year back. Maybe on direct questioning, notice that she has been growing a bit more than what other peer group is. No significant complaints. So this is a common garden typical variety of the early presentation of puberty. Now when you have to look at what exactly constitutes the definition of precocity, that is most important. The definition is 8 years in girls and 9 years in boys. We leave boys ahead. And there are some controversies in the definition. If you look at the data, the graph onto your right is showing that there is a gradual declining age of menarche. There is some stability in the last couple of decades, but there is gradually declining trends, mostly data originating from the African Americans. But nevertheless, as on date, the most valid definition is 8 years, which holds good. Some data to suggest that it is only the thelarche which is coming down, but not menarche, because the onset of precocity is appearance of any pubertal features. So what are the 3 types of precocity what you look at? The classical common garden gonadotropin dependent precocious puberty is one of the things. So it is centrally driven, and you have gonadotropin independent precocity, also known as pseudo precocity. Ideally speaking, you should not use that term. Ideally it is either gonadotropin dependent or independent, or some other variants which you look at as normal variant, because identification of normal variant is essential, because in some patients when not to intervene also matters. So these are the 3 types of precocity what you look at in girls. History gives you most of the diagnosis, and sometimes you require investigations. What are the important histories what you look at? What are the pubertal signs which have come? What are the chronological order which they have come? Time gap between the appearance of these features, any other systemic features which the child has, all those things make sense. And preferably you have to examine the child head to toe naked to pick up some clinical clues which are going to make or break your diagnosis easily. Goiter and DTJ I have kept as last, but one of the commonest ones is still a independent precocity because of a primary hypothyroidism also is common. So these are some of the clinical findings which patient may have, and which will suggest some underlying diagnosis. You can have abdominal pain with gonadal malignancies, and anthropometry obviously becomes the key factor. Cephalomacules, bony swellings, history of exogenous sex steroid usage, and presence of hyperandrogenism, and any neurological features, unusual virilization features, or vaginal bleed. Some of these things will give you a possible diagnosis, either a gonadotropin dependent or independent variants. So how do you evaluate initially? If it is gonadotropin dependent, usually you have sequential progression of pubertal features. Typical growth spurt is always there, and bone age is obviously advanced, and I will come to ultrasound and others later, but you have a typical USG findings which support your diagnosis. You have independent variety which may be predominantly of skin signs, bone signs, other things may be there. You may have abdominal mass, and there may be some discordance between the adrenarch, thelarch, like that. And the normal variants generally don't occur at 5-6 years of age. The normal premature thelarch, premature adrenarch, they are all at 1 to 2 years of age group. So if somebody comes at a later part of the childhood, don't consider the benign variants. And obviously the benign variants, there is not progressive, and you have growth velocity and bone age being normal. These are the benign variants of precocity, what I have said. The premature thelarch usually seen at 1 to 2 years, or adrenarch at 4 to 7 years. Some data to suggest that children born as SGAs with more catch-up growth would have this feature as more common because of increased sensitivity of the adrenal axis. But nevertheless, the important factor is to not to miss out any true precocity in these patients, so that you are not losing out the opportunity of correcting the abnormality inside. These are some of the salient clinical features which I have shown. Okay, phyllomacules, dysplasias, goiters, and some macroorchidism in hypothyroidisms. These are our 3 reports. Why I showed that is, the thyroid is actually importantly affects the puberty. If a girl with true precocity is not gaining height, possibly there can be coexisting hypothyroidism, which also should be considered, which also should require treatment accordingly, and some of the associations with pineal glands also have been reported. When you have to diagnose somebody with precocity, a simple hormonal panel of doing a LH and estradiol and 17-OHP will do the job. If the basal ones are not giving you the diagnosis, you can do a stimulated panel of the same things, and imaging more or less confirms your diagnosis rather than gives you the diagnosis. So it is important to understand that diagnosis is always biochemical. Basal LH more than 0.3 or estradiol more than 10 will give you a diagnosis. If suppose they are not very confirmatory or not very falling in place, then maybe a stimulated one you can do 100 micrograms of decapeptyl, and then you do a LH at 3 hours. I am just giving you one of the values. There are plenty of studies which looked at 4 hours, which looked at 24 hours, which looked at 3, 4, 8, like that. Different sensitivities, different cutoffs, but this is one of the most widely accepted I am giving you. And estradiol at 24 hours possibly gives you the support. If you are suspecting any late onset CAH or something, the 17-OHP will give you a clue. If the basal one is more than 2, you do a synactin stimulation, and then a stimulated 17-OHP more than 10 supports the diagnosis of late onset CAH. The bone age estimation, conventionally we follow the Grulich-Pyle or Tanner-Whitehurst method. The other mechanisms, the bone experts and all are there. There are softwares which have given you you upload an X-ray and then it gives you the exact bone age. But more or less, the important way is the bone age advanced than the chronological age by at least 1 standard deviation. It indicates that bone age advanced and is a cause of concern in a patient, and you require to address this patient. Pelvis imaging, what all to look for in the ultrasound. Again, there are multiple factors as I have given. There are so many things which you look at, different sensitivities, different specificities. Some of the important ones which I have highlighted, the transverse diameter or the fundus of more than 0.8 or pear-shaped uterus over the tubular shape, all those things will give you a clue that it is actually a true precocity rather than a pseudo-precocity. Ovarian parameters have not been so well validated in the ultrasound. Always the question comes, should we do neuroimaging or not in a girl who is in that age group of 6 to 7 years? Lot of debates on this. Generally, if somebody is got below 6 years onset of puberty, you should always image them without fail. If somebody has got progressive neurological features associated, you should do an imaging. And if somebody has been diagnosed at maybe 3 years or 4 years and then you are following them up, maybe a repeat imaging also makes sense. Case to case basis between 6 to 8 years, not routinely recommended unless you have a high index of picking up any lesion, you can do it at that point of time. So the approach to precocity: simple clinical examination to document precocity, and after ruling out the common garden hypothyroidism, you look at the stimulated and basal LH and estradiol. If both are high, it is gonadotropin dependent. If you have only estradiol high and LH low, it is gonadotropin independent. And if both are normal, it is just a benign variant. So that is what is the basic nutshell whenever you are approaching a patient of precocity. Some data, like this is all clinical, and obviously our colleagues in the West have gone further ahead to look at the kisspeptin gene, which is the mechanism behind the reactivation of the hypothalamo-pituitary gonadal axis. You have some families which are described with the kisspeptin mutations and the mecarin 3 mutations, which actually are the monogenic causes of precocity. So some of them, if you have increase in the levels of kisspeptin in the blood, obviously it will cause more say early stimulation reactivation of the gonadal axis. So some of the recent advances, the issue regarding identification of pubertal onset is by Thelark, and with increasing incidence of childhood obesity, to identify the breast development in a obese girl is a difficult one. So you would more or less look at lipomastia as possibly a breast development. So that is why ultrasound also has been put as a marker which will give you a correct identification of the glandular tissue. The second one is about the use of color Doppler in the uterine artery flows, which again will pick up a true increase in the flow of the velocity to pick up that there is actual stimulation of the increase in the uterine blood vessel, which is going to reflect that there is an underlying hormonal activation and there is a true precocity. And as I said, the genetics, which makes a lot of role as far as stimulation of this pubertal is concerned, and you have some serum levels of mecarin 3 and kisspeptin levels which are coming up, some genetic analysis also in some patients. So to conclude, puberty is a complex biological process of sexual development. There is no doubt about it, because the same axis was there dormant and then it gets stimulus at an appropriate age. But you do have a trend towards earlier age now, maybe 7, 8, 9 is the general age group now it is coming up. And what key factor is, what are the progression of the features and what are the sequence of events, and bone age is the key factor in all patients of suspected precocity. Any advanced bone age, you have to intervene, find out the etiology and intervene, and detailed evaluation in sometimes to pick up the CNS lesions. And some of the data to suggest that this progression or early occurrence of puberty is because of the endocrine disruptors, which I can see plenty of them in this room, but nevertheless we have to live with them and then maybe identify ways and means of overcoming with them. Early therapy obviously will give you the optimum adult height, because that is what we are more concerned about, the early epiphyseal fusion, and more or less psychosocial maturation of the girl child to handle the menses also is important. So we need to give that child adequate age group, mental makeup to actually deal with the issues concerning the puberty. I have finished here. Any questions or comments I shall be happy to take.